Welcome everyone. We're really glad that you could join us. I'm Aaron DeVore, and I'm the founder of the Chair in Transgender Studies and the Transgender Archives and the Moving Trans History Forward conferences. And I want to introduce our speaker. Karina Villaluna is a Fraser health-based family nurse practitioner and a University of Victoria alumna, a University of Victoria graduate. She provides comprehensive longitudinal primary care for patients of all ages with a specialized focus in the provision of gender-affirming care. Karina is passionate about providing compassionate, continuous, and inclusive care that is as scientifically grounded as it is deeply personal. So the title of Karina's talk is Enabling Access, Factors Influencing Nurse Practitioner Delivered Gender-Affirming Care in BC. So I turn it over to Karina.
Perfect. Thank you. Okay, so let's get started. Thank you so much for having me and my supervisor here today to present our results. So I'll be talking about our research project that looked at factors influencing the delivery of gender-affirming care by nurse practitioners in British Columbia. So we're very excited to share these results. It's a recently completed project for us. Okay, this is the agenda for today that I hoped to cover during our time together. And I also would just like to quickly do an acknowledgement. Begin by acknowledging that I live and work on the ancestral and unceded traditional territories of the Musqueam, Squamish, Tsleil-Waututh, and Kikate nations. I feel incredibly lucky to live and work in the areas now known as Burnaby and New Westminster, and I recognize the continued stewardship of these lands by Indigenous peoples. So, I have no conflict of interest to disclose for today. So we can get right into it. So this research study that I'll be presenting today is the result, or rather an extension of the capstone project that I completed during my graduate program at the University of Victoria at the School of Nursing. My capstone thesis at the time was that nurse practitioners can integrate gender-affirming care, or GAC, into their primary care practice to improve healthcare access and reduce stigma for gender-diverse individuals. I conducted a literature search and reviewed 38 articles to gain an understanding of the experience of gender-diverse individuals who seek gender-affirming care services and the clinicians who provide them. Okay. So the literature highlighted that gender-affirming care access is hindered by negative experiences and the lack of knowledgeable providers. The limited access to gender-affirming care impacts mental health, and that many gender-diverse individuals seek knowledgeable, patient-centered, and compassionate GAC providers. I think that goes for any type of healthcare, that we seek. We look for those compassionate providers. Before I go further into this talk, I just want to explain some important terminologies. First, what do we mean by gender-affirming care? So the World Professional Association for Transgender Health, or WPATH, defines gender-affirming care as a holistic and multidisciplinary care strategy involving various health disciplines to provide gender-affirming interventions, primary care, and chronic disease management. So the provision of these gender-affirming interventions would involve collaboration among various health professionals, including those listed here in this slide. Okay. So the government of BC defines gender diverse as multiple types of gender identities that fall outside cisgender and or binary understandings of gender. For the literature search, the focus was to understand the experiences of transgender and non-binary individuals. The experience of intersex person was unfortunately beyond the scope of the capstone project. Interesting to note was that in May 2021, Statistics Canada conducted their first survey that collected information about sex at birth as well as gender identity. And almost 60,000 Canadians over 15 years of age identified as transgender, and a little over 40,000 as non-binary. So of these gender diverse Canadians, 67% are younger than 35, so they will require longitudinal primary care. Um, so, and so longitudinal primary care provided by either the GP, a general practitioner, or a nurse practitioner. And so, who is a nurse practitioner and what do we do as primary care providers? A nurse practitioner is a registered nurse with advanced clinical training and graduate level education, and who is licensed to diagnose and treat both acute, episodic, and chronic conditions. We can order tests, we can prescribe medications, perform minor surgical procedures, and most importantly, we coordinate patients' care through referrals to other specialists. So why is it important to know about NPs providing gender-affirming care? And what are the healthcare access issues that NPs can advocate for? So, based on literature, gender diverse individuals experience significant health disparities and they struggle to access routine primary care, as well as gender-affirming care and screening for sexual health and cancer. The barriers identified in the literature included their fear of being discriminated by their own primary care provider, lack of parental or family support, as well as a limited number of primary care providers with expertise in GAC. Other factors barriers included the geographical location of gender-affirming clinics. Most often they are in urban centers rather than in rural areas. And then last, medical insurance coverage for therapies. But this last point is probably more pertinent to the US population, as in BC, we now have a new national pharmacare plan that fully covers hormone therapy, although that's initially for menopause treatment. It's now kind of translating to providing easier access for gender diverse individuals to have or to receive hormone therapies like estrogen. It's different for testosterone. There's still some costs that may be a barrier for some. So families or support groups of the gender diverse individuals also experience difficulties in navigating healthcare as they support their family members in their journey to seeking GAC. So the limited or lack of access to GAC impacts mental health, and it has been noted in literature, including increased despair and suicidality. But for those who pursue gender-affirming care, higher quality of life scores have been observed, especially for older adults who pursued later life alignment of gender identity and body. There's limited research exist on the experiences of transgender people of color, though, in healthcare. But of the available studies, they indicate they face severe psychological distress and gender inequities compared to their white counterparts. So not only the patients, not only their families, but also providers face challenges when delivering gender-affirming care. And with this in mind, we wanted to know how can NPs face these challenges to deliver care and help ease the inequities experienced by our gender diverse individuals. How can NPs help with addressing these health disparities? So in BC, gender diverse individuals experience significantly long wait time. For children or adolescents, approximately 2 years, and then for adults, 6 to 12 months, depending on provider and clinic availability. So NPs as primary care providers can be the first step in connecting to GAC and other health resources. And by doing so, perhaps we can improve healthcare utilization. NPs can provide GAC as they are qualified through graduate level nursing education and clinical experience. However, many NPs may hesitate to do so due to the complexities of care. And depending on where they practice, there may be legal and political considerations that may be challenging for them to overcome on their own. Okay. So the Canadian Nurses Association has an advanced practice nursing framework, and this provides guidance on the NP's clinical practice, can help NPs shape our knowledge and understanding of different medical conditions, but also of gender identities, can help provide us confidence in practicing patient-centered care, and also inspire advocacy work for equitable access to healthcare. NPs have the regulatory authority to diagnose, order, interpret, test, and prescribe treatment, which can be very helpful for gender diverse individuals who require diagnosis in order to access certain medical and surgical services. And this is just a quick slide of provided specific domains from the EPN framework, along with their corresponding competencies that explain how provision of gender-affirming care is within the scope of NP's practice. The competencies range from knowledge possession, analysis of complex determinants of health, advocacy for equitable care, research, and self-awareness in practice. So when I did the literature review, I looked at also about the clinician's perspectives on providing GAC and what challenges were identified. A study by Solet et al. Showed that several clinicians had no formal education training on transgender health. In other studies, clinicians voiced their knowledge gap and cited limited scientific guidance as a barrier to gaining comfort and confidence in providing GAC. There's also limited trans care competent allied health professionals that clinicians can reach out to help with providing GAC care. And then again, they talk about geographical area of practice as a limiting factor. And lastly, moral dilemma that may be experienced by some practitioners whenever they're providing GAC, particularly to children that may be facing conflicting supports or lack of supports from parents or family members. So all of these findings sparked an interest for us to understand the practical experiences and challenges of nurse practitioners in BC regarding the delivery of gender-affirming care. And so this was how the NP Bridge Research Project was developed. We created a research proposal and received approval from both the UVic and the BC Harmonized Ethics Review Boards to conduct the study. And then our objectives were threefold. First, to examine the barriers and facilitators at the institutional and individual level that are influencing the provision of GAC by BC nurse practitioners. Second, to understand the resources utilized by BC NPs to integrate GAC within their practice setting. And lastly, to identify the types of gender-affirming care services provided already by NPs in BC. So, in terms of the methodology, the NP Bridge research is a cross-sectional study involving the collection of data through an anonymous electronic survey containing a total of 19 quantitative and qualitative questions. Convenient sampling was utilized to recruit licensed NPs in BC, first through the Nurses and Nurse Practitioners of British Columbia's research recruitment webpage. And due to the low recruitment numbers, we had decided to also do targeted recruitment through the 4 health authorities that you see listed here on this slide. We were unable to include the institutions under the Provincial Health Services Authority, including BC Children's Hospital and BC Women's Hospital, just due to organizational priorities at those institutions that at the time that we were trying to enroll into the research survey. Our sample size goal was 100 participants, and our final sample included 99 participants. We performed descriptive statistics and chi-square testing on our quantitative data and an inductive thematic analysis on our qualitative data. This is the NP Bridge Survey landing page that participants would see after they click on the link included in the emailed invitation to participate. And so let's look at who were our participants. Not surprisingly, majority of the participants are female. 40% of participants were between the ages of 35 to 44. And in terms of years of practice, NPs with 0 to 5 years of practice comprised almost 40% of our final sample. And lastly, 44% of participants practice only in primary care, while 39% have a combined primary care and specialty care practice. Many of the participants did not specify, unfortunately, the patient population in their practice, but most primary care providers would see all through the ages in their clinical settings. And in terms of geographical area of practice, a little over 40% of participants practice in the Lower Mainland. So of the 99 participants in the study, 65% provided gender-affirming care. And of those who provide gender-affirming care, 56 provide continuation of hormone therapy management after this has been initiated by a specialist or another primary care provider who has experience in GAC. Hormone readiness assessment was provided by 37 participants and surgical assessment by 22. When we ask how NPs in BC share information or raise awareness about their inclusive practice, 80% of participants reported that they asked patients about their preferred name and pronouns to get them engaged, while over 70% will share GAC information when asked by the patient or family. And then a little over 50% of participants reported that their clinic spaces showed a welcoming message to patients of all gender identity. And then during those encounters, when providing GAC services, NPs would most often be asked about referrals to gender-affirming medical therapies or surgeries. Other questions addressed by NPs were related to counseling services, assessment for upper or lower surgeries, and as well as mental health services. NPs in BC would refer patients for GAC services either to a gender clinic, a colleague in the same or nearby clinic who provides GAC, or another specialist like an endocrinologist. And almost 30% of participants could not estimate an average wait time between the referral and the first appointment involving GAC service. Meanwhile, 25% of participants reported an average wait time between 1 to 6 months. One participant reported longer than 18-month wait time, and one other reported more than 24-month wait time, which prompted this NP to provide more counseling and supportive appointments as their patient waited. Longer wait times were noted more often with surgical assessment referrals. Now, our research project survey included pre-specified facilitators for participants to select. And based on chi-square testing, the Transcare BC Primary Care Toolkit, the Transcare BC website, and the RACE or ECASE Transcare Health phone line consultation were deemed as statistically significant facilitators to providing GAC. The survey also included pre-specified barriers, and among these options, the statistically significant barriers were the limited knowledge, practice, or experience in assessing the capacity and rights of gender diverse youths to consent for GAC. Next is complexity of patient panel. And third is the practice area such as urgent or specialty care practice. So these three were identified as the most kind of common reasons for having challenging ability to provide GAC in clinical practice. Moving on to our thematic analysis, in terms of current and potential facilitators, the responses were categorized into themes of mentorship and collaboration, continuing educational resources, and systemic support and incentives. Participants shared kind of various factors that enabled them to provide GAC, including having shared resources and presentations by NP colleagues, proximity to a GAC clinic, or easy access to specialist consultation services were definitely facilitators. And also they talked about informal personal experience within the community and mentorship at a local gender clinic were highlighted as helpful resources. For continuing educational resources, they highlighted the use of the Transcare BC resources, such as the Extension for Community Healthcare Outcomes Program and online GAC courses, along with the Ontario Rainbow Health Guidelines. With regards to systemic support, participant indicated that incentives to provide GAC services and investment in research on GAC could be facilitators in practice as well. Moving on to barriers, it was interesting to note that participants reported more barriers than facilitators to incorporating GAC services into their clinical practice. The major themes derived were providers' practice characteristics, patient access and engagement, education and continuing competence gaps, ethical concerns, and institutional constraints. Looking at providers' practice barriers included having a small number of patients in their clinical panel who need GAC, so makes it a bit difficult to maintain competency. A participant identified the lack of GAC referrals received at their clinic as a limiting factor, and appointment time constraints, limited time to gain knowledge, along with clinic capacity and mandate were also identified as barriers. Clinic mandate was particularly regarding specialized clinics that often see single medical condition focus, so it's not more of a broad primary care practice. The theme of patient access and engagement pertained to patient barriers that were identified by the participants, and these included challenges related to rural living, limited transportation to get to those clinics that have GAC services. They also reported that the lack of family support and patients' declining primary care attachment despite seeking gender-affirming care as been barriers to providing this care. For the theme of education and continuing competence gaps, a number of factors were noted, including lack of evidence-based guidelines, limited research or resources or examples of responses, as well as competing subspecialties for NPs practicing in primary care, and challenges to maintain competence of skills in providing GAC. One NP noted that they had to do all the work of learning about gender-affirming care on their own time, as they did not have GAC teachings within their nursing program. One NP expressed their dilemma about providing GAC in young patients, as shown in the slide. This NP firmly believes in GAC, but also had some fear about young patients receiving interventions. And they are aware of this concern and attribute it likely based on their lack of knowledge, which brings to the forefront how we need to invest in more research and provide GAC content in education programs. At the institutional level, some barriers identified were a lack of official signage or overt advertising to engage the LGBTQ population, And a couple of participants expressed the need for more supportive work environments to provide gender-affirming care. So in summary, gender-affirming care is being delivered by NPs, but access is still limited. And so gathering data on the barriers and facilitators for BC NPs is a first step to determine how NPs can be better supported at the individual, interprofessional, and institutional levels to incorporate GAC in their practice. Constraints within practice settings, such as short appointment times, institution and clinic mandates, patient panel volume, and limited exposure and application of knowledge impacts the confidence and competence of NP. Access to facilitators, such as ongoing GAC educational resources, mentorship, and collaborative support can help NPs overcome these barriers and hopefully enable them to provide equitable care. A note about our study's limitation. Obviously, the first is the small sample size of 99. There are approximately between 1,100 to 1,600 licensed NPs in BC, so a small representation compared to the large number of NPs practicing in BC. Second is the inherent response bias with surveys. And then also commenting about our limited recruitment pool. There's certainly more areas that we could recruit NPs outside of the health authorities. There are primary care networks that could also be included. And then lastly, just the data accuracy in terms of the geographical area of practice subgroups, which we've had to make some changes as we increased our recruitment pool. We've had to add health authorities as area of practice subgroups rather than like focusing mainly on geographical divisions. And in terms of recommendations, certainly, increasing awareness about educational resources available to NPs would be a great start to promoting confidence and competence. Advocating for accessible GAC at the organizational level to address those institutional constraints. Promoting peer collaborations and network, like Transcare BC has an email distribution list where you could connect with other GAC providers and ask questions about who can we refer to for upper or lower surgeries in, on the Vancouver Island or in interior health. So you have a quick connection to those collaborators. And then in terms of education, certainly advocating for GAC content in graduate program curriculum, and also maybe looking at the BCCNM's scope and entry-level competencies to hopefully incorporate provision of GAC as an entry-level competency for NPs in BC. And before I end this talk, I would just like to share some resources that practitioners and also the public can use to learn more about providing gender-affirming care. Transcare BC has a great tool that provides strategies to organizations and service providers for creating inclusive spaces and clinical practice. And if you recall in a previous slide that only 50% of participants reported their clinic showing welcoming signs. So there's definitely room for improvement in this area. If we can commit to even a small, simple step of putting welcoming signs, to incorporate into our inclusive practice would be a great start. As well as raising awareness that these resources are available can be a first step in incorporating gender-affirming care services in an NP's practice. And with that, I want to thank you all for your attention and for sharing your time with us. Thank you to the Chair in Transgender Studies for inviting us to present our results.
Thank you for that. Just a few words to just wrap up on the session as a whole. I thank Karina for the wonderful presentation, and you stood up extremely well to lots of questions. And I thank everybody else who attended. So thank you very much, and I hope we'll see you again soon. And I want to say finally a thank you to Jay, who you can see on the screen, who is responsible for making sure that this all worked well, and Zach, who was with us earlier on. So thank you again to everybody.